Let me share some high-level considerations around this trial. To orientate you again, here is the curriculum wheel, or the steering wheel, on sections that we had to navigate during this trial. In terms of our intent in question, the Provincial Renal Agency had already identified improving access to kidney transplantation was a key priority for the agency and for the patients they serve. And so we're very fortunate they agreed to test a strategy they already planned to roll out in this multi-center trial. And the trial question was whether renal program-wide use of this multi-component intervention was superior to usual care in completing key steps towards receiving a transplant. And because it's difficult to sometimes roll out an entire strategy to the entire province at once, this allowed us to test the intervention in this way, promising that everyone would receive the intervention once the trial was over. Our primary intent of the trial was to inform whether the Provincial Renal Agency was on the right track and should continue the strategy, or whether they needed to make course adjustments and modify their approach. This was a cluster randomized trial, where the 26 renal programs, each one was a cluster. Now, there is no magic about randomization, in that if you randomly allocate 26 clusters into two groups in a parallel trial, by chance alone, you could get substantial imbalance on the measured baseline characteristics between those two groups. So using covariate-constrained randomization, we minimize this, and that's why our table 1 in the trial shows that the measured baseline characteristics were similar between the two groups. For those that are interested, this is described more in the trial protocol. Thinking through both the trial implementation and the intervention implementation was very important. The trial was embedded in routine care across 26 specialized clinics for patients approaching the need for dialysis, 26 home dialysis programs, and 97 hemodialysis units. And more than 3,400 nurses and 230 nephrologists provided this care. So from the trial perspective, we had to determine how we were going to implement the trial and obtain the data for all the programs. And then with the intervention group, we had to figure out how are we going to implement this complex intervention in a way that there's going to get major uptake and result in the gains that we want. For this reason, we did a separate process evaluation where we surveyed and interviewed health professionals to understand, did the intervention address intended barriers, and did the implementation occur as planned? For more details on the process evaluation protocol, you can see this paper from my colleague, Dr. Seychelles Johanna, and the paper with the results of this process evaluation is currently under development. This trial had many interesting statistical considerations. And for more details, you can see the statistical analysis plan published by Dr. Steph Dixon. And what was interesting is we used a multi-state model for the primary outcome of this trial. Certainly we looked at all steps in isolation, but to look at the totality of people moving through the system, we used this multi-state model, which is not that common and required some thought and development for using it in this context. In terms of the ethics, consent, and regulations, this trial was developed and strongly supported by a broad group of healthcare professionals, healthcare administrators, regional renal programs, patient groups. And everyone thought it was very sensible to generate robust estimates of this intervention effect. Everyone was going to receive the intervention. It's just that there was time that a first group would receive it during the trial and then everyone would receive it after the trial. And so the Research Ethics Board at Western University approved this trial to have waived patient consent, and that the 20,000 patients in the trial would not be notified that they would be in a trial. You know, ethics, consent, and regulatory issues are complex topics. And when we conduct research, we certainly want to do it in a way that's maintaining public trust, and also that we're doing things that we're contributing to learning healthcare system and that the trials are practical. I had the fortune of speaking to someone who was actually on dialysis who was a health services researcher, and they've now received a kidney transplant. And I was discussing the ethics of this trial with them and their perspective. And from their point of view, they were saying that the subject of the research is important. And in this case, they saw the unit of the intervention being the healthcare system and not individual patients themselves. Many traditional bioethics principles are individualistic and are about the protecting the rights of the person. But given that there are many aspects of healthcare that are not discussed with patients, they could appreciate that it would be very odd to disclose that a person was in a trial with the goal of trying to improve access to care, and how people in the usual care group would feel but not receiving it initially, and what kind of considerations would that be. So again, a complex topics, but these are the type of things we were discussing during the trial. The patient-facing trial materials, particularly the educational materials, are described in the protocol. This trial was only made possible through a tremendous amount of partnerships and support. There were the 2 provincial renal agencies that were behind this trial, patient and family advocacy groups. And an interesting thing about this trial is that we now partner with patients on many aspects of trial conduct, determining what exactly is the right question and the intent, to design aspects, to thinking about the ethics, consent, and regulations, the patient-facing materials, interpretation of the trial results. Here, patients felt so strongly about this that they wanted to be a part of the intervention in the form of the Transplant Ambassador Program, which was very interesting in this trial context. In terms of Indigenous rights and data sovereignty, this is a complex area that our team is continually learning more and more about. We recognize Indigenous peoples in Canada are disproportionately affected by kidney disease, and so we want to contribute to a history of randomized trials done in a safe, respectful, culture-appropriate way that allow Indigenous peoples, like all peoples, to participate in positive way in trials. And in this particular case, achieving the goals of the Truth and Reconciliation Report. We are so grateful to be guided by one of our patient partners who is chair of our Indigenous Patient Renal Council, and aspects like the educational materials, some of them featured Indigenous patients and describing their experiences with transplant. And we had many more plans in the second phase of this work to address this in even better ways. On a personal note, we were very, very saddened to learn that this individual had unfortunately passed away in the spring of 2024. And that profoundly affected the team. Many of us have been working with her for over a decade. As a physician, I'm involved in the care of patients, and unfortunately the median survival on dialysis is around 3 to 4 years. But working with a patient partner in this context, it's even much more profound in the sense that you're working as team members on protocols and videos and a number of things. And so processes that we have that allow patients affected by serious illnesses to step away from trial teams when they need to, creating spaces after very serious awful events occur for bereavement, are things that we appreciate need to be done in the context of these trials. In terms of quality control and oversight, the occasional step a patient received towards receiving a transplant was not recorded in healthcare databases. For example, we saw on occasion that someone received a kidney transplant, but we had no record they actually referred to a transplant center, which is not possible. You have to be referred to a transplant center in order to receive a kidney transplant. Fortunately, this didn't happen very often. And in our trial documentation, we described how we were imputing those missing steps prior to performing any outcome analysis. We use the large healthcare databases of Ontario, to meet the data needs of this trial. What was required was actually a data sharing agreement between the provincial transplant organization and the renal agency that allowed data to come from the transplant centers to the renal agency to generate the reports that were an aspect of the intervention. And as well, both these data streams funneled into ICES that then allowed for the analysis. Inclusion, diversity, equity, and accessibility is another complex topic. In terms of the trial team, we had excellent representation from multiple different stakeholders. Another aspect is how we reported the results. This trial included every single patient in Ontario with advanced kidney disease who received care during the trial period. But we elected not to report race, ethnicity, and the baseline patient characteristics. Although it can be very helpful to show the types of patients represented in the trial, there's also this consideration around how accurate is the data, and is it being presented in a way that meets current standards. One of the standards is that it's self-determined, and in this case we couldn't be confident that the data that we had available to us met that standard, so we elected not to report this. With respect to the financing and resources, several aspects of this intervention were delivered by the renal agency, so that was not a specific trial cost. When we look at the actual cost of conducting the trial, it came in around $1.5 million Canadian. So I hope this was useful in helping show what trial teams navigate when undertaking trials. And thank you so much for listening.